Assalamu alaikum. Welcome to all in today's video lecture. Our lecture is about adenomyosis and sub-fertility. Adenomyosis is now the most common gynecological problem among the women, which are rising day by day, and we will discuss in brief about adenomyosis and its great impact on sub-fertility. First of all, adenomyosis. What do you mean by adenomyosis? Adeno means gland, which is here is ectopic gland, and myosis mean muscular hyperplasia and hypertrophy. And it as a whole, adenomyosis is a benign invasion of endometrium into the myometrium, producing diffusely enlarged uterus, which microscopically exhibit ectopic, non-neoplastic endometrial gland and stroma, surrounded by hypertrophic and hyperplastic myometrium. From figure, we show that this is the uterus, these both are ovary, and this is the pair of fallopian tube. Okay, now this is the endometrial cavity and lined by endometrium. It contains endometrial stroma and gland. And when we will call it adenomyosis, when there is invasion of endometrial gland and stroma into the myometrial layer. This is the myometrium of the uterus, and associated with myometrial hypertrophy and hyperplasia. This condition will be called as a whole adenomyosis. That is benign invasion of endometrial gland and stroma into the myometrial layer of the uterus. It will be called adenomyosis. Okay, next, the classification of the adenomyosis. We can classify it in several ways, and we will now discuss about the most common classification of the adenomyosis. First of all, on basis of imaging, that is MRI and ultrasonography, we can divide adenomyosis into two types. That is, one is diffuse adenomyosis and another is focal adenomyosis. Focal, when we will call diffuse adenomyosis, we will call diffuse adenomyosis when if it is uterus and it is the myometrium, and when there is presence of endometrial tissue and gland all over the surface of the myometrium, we will call it diffuse. And another is focal. It will not present in the whole surface of the myometrium. It will just present in one portion of the myometrium. It again can be divided into adenomyomata and cystic adenomyosis. What we understand by adenomyomata? Adenomyomata is there is focal presence of endometrial gland and stroma, and it will be surrounded by layer of hypertrophied muscle or myometrium. And what we will understand by cystic adenomyosis, if it is uterus and it is the myometrium, then there is cystic collection of fluid is present, and this collection will not be hypertrophied muscle surroundings. That is, in case of adenomyomata, there will be presence of hypertrophied muscular layer or hyperplasia muscular layer surrounded the endometrium gland and stroma. But in case of cystic adenomyosis, there will be only presence of cystic or collection of fluid into the endometrial gland and stroma, but there will be no hypertrophied or hyperplasia muscle surrounding this ectopic endometrial gland and stroma. Okay, now the another classification, it depends on extent of disease. Okay, if we show from the figure, if it is uterus and it is the cavity and it is the myometrial layer. Now on the basis of extent of disease or adenomyotic tissue into the layer of the myometrium, it is divided into mild, moderate and severe. When we will call it mild, if in total it is 100%. When there is invasion or extent of disease less than 25%. If it is 50%, it is 20%. Less than 20% of the extent of disease we will call it mild affected or mild type of adenomyosis. If there is extent of disease within 25 to 50% are affected, 25 to 50% we will call moderate, and if it extends or affected more than 50%, if it is 25, it will be 25 to 50%, and it is more than 50%. Okay, next another classification, it's based on infiltration of endometrial gland and stroma within layer of the uterus. Okay, it is type 1, type 2 and type 3. When we will call type 1, if it is uterus, it is uterine cavity, we will divide the myometrium into 3 layers. One is inner myometrium, then is middle myometrium, and another is outer myometrium. To understand the in details about adenomyosis, first of all we have to know about the junctional zone. What is junctional zone? Junctional zone is the area of inner myometrium. It is the area of inner myometrium which overlies the endometrium. This area is known as junctional zone. Area of inner myometrium which overlies the endometrium is known as junctional zone. Very much important to understand adenomyosis disease extension and the MRI ultrasonographic finding. We have to know about the junctional zone. So junctional zone, I again repeat it, it is the area of inner myometrium which overlies the endometrial tissue. This zone is known as junctional zone. Okay, if there is infiltration of endometrial gland and stroma within the layer of uterus, this is called type 1. Up to junctional zone there is infiltration, it is type 1. If there is extension of disease up to the middle myometrium, if there is infiltration of gland and stroma up to the middle layer, it will called type 2. If there is extension up to the outer myometrium, then it will be called the type 3 adenomyosis. Okay, this is all about in short classification of adenomyosis. Now the important topics, that is the risk factor. What are the risk factor of adenomyosis? First of all, there will be age factor, that is age is more than 40 years. More than 40 years, this female or women are most affected by adenomyosis. And multiplicity, the number of childbirth is more. They are mainly affected by adenomyosis. And there is history of previous cesarean section or uterine surgery. They are also affected by adenomyosis. Then smoking is a culprit or important factor in adenomyosis. And another is endometrial hyperplasia. So these are the most common risk factor which affect women to be adenomyosed. And it is previously epidemiological scenario, but now it's a matter of concern. The risk factor is shifting. Now recently we found the adenomyotic patient not age more than 40 years. Also we found it in the young women. And the young women with come to the gynecological OPD with the infertility, then heavy menstrual bleeding with pain or dysmenorrhea, and abnormal uterine bleeding. This is now the matter of concern for the doctors, and it is also a producing diagnostic dilemma for the gynecologist, that shifting of the epidemiological scenario. The previous was confined into the age more than 40, then multiplicity, previous cesarean section, but now we found the young women, those who are not even give childbirth or previous cesarean section. They are also facing the adenomyosis disease and come with OPD, and it is a matter of concern and also producing the diagnostic dilemma, and there is conflict with other disease. Okay, then we will discuss in brief the pathogenesis of the adenomyosis. So what is the pathogenesis? That is the how adenomyosis formed, what factor changes in our body that producing adenomyosis. There are several theories regarding adenomyosis, and we will discuss the most popular theories there's regarding pathogenesis. Okay, first of all, invasion theory. Invasion of endometrial vessels into the myometrium. Then the third theory is tissue injury and repair theory. It also known as microtrauma to endometrial and myometrial interface, that is auto-traumatization. Then de novo metaplasia theory, it also known as stem cell theory. Then another is outside to inside invasion theory. First of all, we will discuss about the invasion theory, that is invasion of endometrial vessels into the myometrium. Okay, we will discuss it in details. What do you mean by what it actually denotes? Endometrial and myometrial interface is breached due to repeated sharp endometrial curettage, cesarean delivery, and prior to uterine surgery. What happened? In case of vigorous endometrial curettage, this is the endometrial layer, and during curettage it is breached. This layer is broken, and this broken layer causes there is invasion. First of all, you have to know there is 3 layers of endometrium. It is the endometrial cavity, the endometrium, if we cut short this, there is 3 layers of endometrium. There is 3 layers of endometrium. The most outer or towards the cavity is 2 layer as a whole, known as stratum functionale. Stratum functionale, or the innermost layer towards the myometrium, it is known as stratum basalis. Okay. In case of breach of the endometrial myometrial interface, that is invasion of stratum basalis into the myometrial layer, it is the myometrium. Okay. Then this is the myometrium. This is the myometrial layer. There is an alteration of the junctional zone due to the prior surgery, uterine surgery, and the invasion of endometrial basalis into the myometrial layer. And the altered basalis invade into the myometrium through the injured junctional zone, enhanced endometrial cell migration and epithelial to mesenchymal transition. Thus, there is developed of ectopic endometrial stroma and gland into the myometrium. It is the one of the pathogenesis theory regarding adenomyosis. Next, we will discuss about the tear theory. What is the tear theory? In tear theory, we can discuss that is there is tissue injury in the endometrium layer, it leads to the production of interleukin-1. This interleukin-1 activates the cyclooxygenase 2 pathway, and there is production of prostaglandin E2. This production of prostaglandin E2 and activation of cyclooxygenase pathway that activates the steroidogenic acute regulatory protein, or in short STAR protein, that and the cytochrome P450 aromatase. This activation leads to formation and aromatization of testosterone, into estrogen. This is STAR protein that causes formation and aromatization of testosterone into estrogen. This causes the increased production of estrogen, and there is production of local hyperestrogenic environment. This leads to again production of hyperestrogenic condition, and there is proliferation of the ectopic tissue into the myometrium and formation of adenomyotic tissue into the myometrium. Next, the stem cell theory or de novo metaplasia theory. Okay, it can be divided into two theories, that is embryonic stem cell theory or adult stem cell theory. Embryonic stem cell theory describes that during Mullerian duct development and fusion, some remnant of embryonic tissue misplaced into myometrium that leads to adenomyosis formation. Okay, we'll see it from the figure from next slide and after discussing. And what is this adult stem cell theory? This cell resides into the basalis near to the myometrium, may cross the endometrial myometrial interface due to injury and develop and proliferate into the adenomyotic lesion. Okay, in this figure we show that During Mullerian duct formation, there may be presence of some remnant into the myometrium, and it further can proliferate into adenomyotic tissue. And in case of adult stem cell theory, there reside the RAM stem cell into the myometrium near to the endometrium, and this shifted into the myometrium, and under the influence of estrogen or other factor, there is metaplasia occur, and this embryonic Adam stem cell, it transformed into the adenomyotic foci and formation of adenomyosis. This is all about stem cell theory. Okay, and then fourth one is outside to inside invasion. Okay, during the retrograde menstrual effluent, it may happen all the time. In case of most of the women, in every cycle there is retrograde menstrual effluent. It may be from cavity, from fallopian tube, it enter into the peritoneal cavity. Okay, and this menstrual effluent, this contains the epithelial stromal stem cell or glandular cell, and this adult endometrial cell potentiate to infiltrate into uterine serosa. This is uterine serosa, and this tissue infiltrate the uterine serosa and penetrate the outer myometrium, that is outer myometrium, and penetrate here and developed into myometrial implant and formation of adenomyotic tissue. This is all about the important theory of pathogenesis of the adenomyotic, and there is another description regarding pathogenesis, that is abnormal genetic and epigenetic factor. These are directly causes the estrogen and progesterone receptor dysfunction and promoting cell proliferation, migration, differentiation, epithelial mesenchymal transition. This leads to inflammation, neurogenesis, fibrosis, and new angiogenesis proliferation. And this abnormal genetic and epigenetic factor can directly causes inflammation, neurogenesis, fibrosis, and neuroangiogenesis proliferation. That is proliferation increase the expression of some factor, that is COX-1 or COX-2, UCN, OTR, and interleukin-1, prostaglandins, nerve growth factor. And in case of fibrosis, there is NRF2 factor, transforming growth factor beta, then matrix metalloproteinase, then LOX factor. In case of neuroangiogenesis, there is increase activin A, then vascular endothelial growth factor, hypoxia inducing factor, transforming growth factor B, then there is expression of matrix metalloproteinase 2 or 9. This as a whole increase promoting cell proliferation, migration, differentiation into the epithelial mesenchymal transition, and leads to formation of adenomyotic tissue into the myometrium and formation of adenomyosis. This is all about the pathogenesis. I know this is a very tough to understand, but I try to make easy for you all. This is the pathogenesis of adenomyosis. Now the important, what are the symptoms, what patient faces for this disease, and tell us into the gynecological OPD. First symptom, most common, is abnormal uterine bleeding. In case of abnormal uterine bleeding, most common we find with heavy menstrual bleeding. Patient will complain that she faces heavy menstrual bleeding during her menstrual cycle. Then she can also complain about the prolonged menstrual bleeding, or there is presence of premenstrual spotting. In case of adenomyomatous polyp, they can also give the complaint of intermenstrual bleeding, but it's not so common in case of adenomyosis. It also present if there is presence of adenomyomatous polyp. Then the important symptom is gynecological pain that include the dysmenorrhea. So patient will come with to us that with the common complaint, there's heavy menstrual bleeding and dysmenorrhea. And pain, other pain may be complained with dyspareunia and chronic pelvic pain, and it may cause infertility and recurrent pregnancy loss. If there is association with deep-seated endometriosis with adenomyosis, patient may complain with dysuria if there is compression in the bladder, or in the rectum there may be complaint with dyschezia. This is all about the symptoms presented with adenomyotic patient. Okay, the most common, important and popular topic that how adenomyosis hampers women's fertility. Okay, we will know about details how it hampers fertility. Adenomyosis hampers fertility by impairment of sperm transport. During sperm transport, if it is the uterus, it is the vagina, it is the fallopian tube, and it is the ovary. Sperm is deposited into the vagina, or semen is deposited into the vagina. Then sperm have to travel a long way for fertilization up to the ampulla of the fallopian tube. But in case of adenomyosis, there is retrograde contraction of the uterine muscle layer. That retrograde contraction hampers the transport of sperm into the fallopian tube. Thus, it affects fertility. Then there is aberrant uterine contractility. There is alteration of adhesion molecule, cell proliferation, apoptosis, and free radical metabolism, and thus it hampers fertility. And there is the abnormalities in the junctional zone, and there is a hamper in the endometrial receptivity of the fetus. Then it causes recurrent implantation failure during IVF. Okay, in the molecular level, what changes occur that hampers fertility? In anatomic level, there is enlarged uterus and distorted anatomy of the uterus, distortion of uterine cavity, and abnormal uterotubal transport. That's changes occur in the anatomic level of adenomyotic patient. What changes occur in the cellular level? There is cellular and nuclear hypertrophy, abnormal shape of nuclei and mitochondria. Abundant myelin bodies leads to irregular muscle contraction due to distortion of calcium circulation, and dysfunctional uterine hyperperistalsis occur in cellular level. And in junctional zone, there is increased thickness of junctional zone, that is disrupted architecture of myometrium into the junctional zone, hyperperistalsis, myometria, hyperplastic myometrial tissue, and increased intrauterine pressure. This as a whole hampers the fetus and to be implanted into the endometrial cavity, and also hampers the sperm transport, and alters in the contractility of the muscle layer and hampers the fertility and produce sub-fertility and infertility to a woman. Now, there are some implantation factors that altered in adenomyosis. In the left side of the figure, we are seeing the factors of utopic endometrium. In the right side, we are seeing the changes of factor into the adenomyotic lesion. What happened here? There is first implantation failure occur due to lack of adequate expression of adhesion molecule, then alteration of embryonic development of gene HOXA10, expression of cytochrome P450 and mRNA, and dysregulated leukocyte inhibiting factor. Then there is impairment of endometrial receptivity by increased inflammatory marker and oxidative stress, and reactive oxygen species is increased, and altered progesterone receptor and estrogen receptor expression. This as a whole occur in the adenomyotic lesion, and this producing the implantation failure of the fetus into the endometrial stratum, into the endometrium. Okay, then there is important slide, that is adenomyosis and its effect on pregnancy. How it affect it? Adenomyosis can decrease the pregnancy rate. The live birth is also decreased, and it increase miscarriage rate, adverse late pregnancy outcome like preterm birth, then